Today we're going to be talking about well adolescent visits. This is something that you'll see commonly in the clinic. So we're just going to go over how you should approach those visits. So just to start off, adolescence is the life stage from age 10 to 24. And that seems like a pretty big age range. And obviously there are a lot of developmental changes that take place during that time. Most times when kids come into the office during this time frame, they're usually for either acute complaints or sports physicals. Um, and it's estimated that 70% of school age children have one single preventive care visit within a 4-year period. Ultimately, we should be striving for 100% of our school age children having a well child visit every year. And it's also good to have your adolescent patients follow up regularly and offer confidential screening and counseling. Because if these patients feel more comfortable with you, they're going to be more likely to access healthcare, um, more likely to have a favorable attitude about clinicians, and also, and maybe more importantly, to share sensitive information if they have concerns about anything. But on the flip side of that, unfortunately, it's estimated that 60% of kids during these visits don't actually get time alone with their clinician. So it's the AAFP recommends doing a psychosocial interview at every visit, every single visit that anyone 10 to 24 comes in for. So first, they want to make sure that you're addressing any acute complaints and routine preventative care. But after doing that, they recommend that you try and spend some alone time with the adolescent if possible. And you'll want to go over the confidentiality policy both in front of uh, the parent and the child together, and explain to the parent, that I always like to take time just to talk with me and your child alone. 9 times out of 10, the parent totally understands and, will leave the room. And then you just move on from there. So the next step is to determine if there's enough time to complete a psychosocial interview. If there isn't, then you're just going to do a brief screen. Tell me about how school or work is going. Um, you know, Briefly asking about emotions. If there's time to do the full psychosocial interview, then then you would do that. And these are the questions that you would ask. So you want to ask about their strengths. What do you like doing? Tell me what you're proud of, those types of questions. Ask about how things are going at school. Is there a particular subject that you like? Anything that you find more difficult? How are your grades? Who do you live with? Do you get along with the people at home? Do you feel safe at home? Can you talk to anyone in your family if you're stressed? Ask about what types of activities they like to do. Ask about drugs and substance use, emotions. Have you been feeling stressed? Have you been having trouble sleeping lately? Have you ever tried to hurt yourself? Ask about their eating habits as well. Sexuality. And again, you always want to use gender neutral language. You don't want to make any types of assumptions. It's always good to ask, are you attracted to guys or girls or both? Um, are they using protection? Have they ever been worried about STDs or getting pregnant? And safety at school, safety at homes. Um, you know, are they around weapons? Are there weapons at home that they know of? Are they locked up if there are? Also, this is another time to use anticipatory guidance and talk to them about, things like bike helmets, pool safety, wearing seatbelts in cars. You also want to ask about social media. Um, have they ever done things online that they wish they hadn't? Um, Texting while driving, how much time do they spend a day on social media? So if you identify any concerning responses, then you're going to want to move on to the SBRIT, which is screening, brief intervention, and referral to treatment. We'll talk about that a little bit later on. If everything seems good with the patient, then don't need to do anything else. Just plan for routine follow-up. And have them come back for whatever reason you would be having them come back. And if the child is healthy and there's nothing concerning that you identify, that might not be until next year. Okay, moving on to the physical exam. First, you always want to take a thorough history if you've never met the patient before. If you have, you want to make sure you're reviewing and updating their past medical, surgical, family history, any medications. Are they seeing any other specialists that maybe you weren't aware of in the past year? You want to make sure you get all of that information, their allergies, and then their social history as well. And this is just a graph of normal vital signs for children across the age span. So you can see, for example, heart rate decreases as people get older, um, blood pressure increases. So just a good reference for you to keep in the back of your mind. And when you're looking at weight, obviously, yes, you want to weigh the child, but you want to look at their BMI percentile, which is comparing each child by age, because um, you can't just look at one child alone because there's such variation, for example, in height and weight between one child for the next, even at their age group. And weight status categories are different for children than they are for adults. So less than the fifth percentile of BMI percentile is considered underweight. A healthy weight is the 5th to the 85th percentile. Overweight is the 85th to 95th percentile, and obesity is equal or greater than the 95th percentile. So while a normal BMI for an adult is about 18.5 to 24.5, you can see how that might be different for a child when you're using the BMI percentile. So if you look at this example up here, a 10-year-old boy with a BMI of 23, so that would, for an adult, fit into the normal category, they're actually considered obese because they're above the 95th percentile. Similarly, a 10-year-old boy with a BMI of 18, so if you're just straight going off of adult BMIs, that would be underweight for an adult. This 10-year-old is actually in the normal range for his BMI percentile. He's about the 75th or just under percentile. So after you've looked at their vitals, you've taken a history, you're going to move on to your physical exam, and really you're just going to do a complete head-to-toe physical exam. Unless there's a reason to do a genital exam, this is not something that you do typically when you're examining an adolescent. But you may have, for example, 16 or 17-year-old sexually active female come in and she's complaining of a vaginal discharge. Of course, in that scenario, you're going to have to do a vaginal exam in addition to some testing. So you really need to use your clinical judgment as to whether you feel an exam is necessary or not. Moving on to sports physicals. So this is something that you'll do both in our clinic, and we also volunteer with Rochester High School where we do sports physicals every year. But a lot of times you'll have people coming into the office to do their sports physicals. And this can be tied with an annual exam as well. But say someone already had their annual exam, you've never seen the patient before, you'll need to still do your own assessment to complete their sports physical. So they're quite common. Approximately 30 million athletes under the age of 18 receive them every single year. And the purpose is really to maximize the health of the athlete and to ensure their safe participation in sports. And as I was saying, this may be the only time they come to the doctor in a year. So you can do it in combination with their annual health exam. So the clearance really depends on the athlete, but also the type of sport. And we're going to look at the form that you fill out, and you can see that they make a differentiation between contact and non-contact sports. So the risk of injury depends on several factors. Obviously, doing something here like bowling is going to be a lot less impact than, say, if you're clearing someone to take part in boxing or speed skating, where there's, a high risk of fall and potential injury because of the speed. So there are some contraindications for participation in sports. Active myocarditis or pericarditis, hypertrophic cardiomyopathy, long QT syndrome. Typically, those will be known before the patient comes in, but this might be something that you're diagnosing through your history and physical exam. Acute enlargement of the spleen. If the patient had tested positive for mono, 10 days ago, they're not going to be cleared to take part in sports. Eating disorders in which the athlete is not compliant with therapy and follow-up, history of recent concussions, poorly controlled convulsive disorder, any type of C-spine injury, sorry, I'm seeing a typo here, but any type of C-spine injury or symptoms concerning for potential C-spine injury, severe hypertension that is not controlled with therapy, sickle cell disease, if they're wishing to take part in a high exertion contact or collision sports, and any time that you suspect a coronary artery disease until it's been fully evaluated. So for the physical exam, at a minimum, you need vital signs, vision, hearing, a cardiovascular exam, and a musculoskeletal exam. And these are also shown on the form that you have to fill out. Genital exam is not recommended for females, and it may be indicated in males if there's a history of genitourinary problems, but 9 times out of 10, again, you don't need to do a genital exam. And the musculoskeletal exam can be brief. You can, come up with your own standardized exam that you do on every patient. But that should be adequate for people who are not having any symptoms. These are some recommendations from the AAFP regarding sports physicals. So they recommend that they be completed 6 weeks prior to physical activity in case any further testing or rehabilitation is needed. You should question everyone about exertional symptoms, the presence of a heart murmur, symptoms of Marfan syndrome, family history of premature serious cardiac conditions or sudden death. Athletes with sustained systolic blood pressure of less than 160 and diastolic less than 100 should not be prevented from playing sports. Athletes with well-controlled asthma who are asymptomatic at rest and with exertion can be safely cleared. And blood and urine tests are not recommended in asymptomatic athletes. So for our sports physicals, we use a standardized form for the state of Michigan, and this is what it looks like. So on the first page, this is mostly filled out by the student or their parent or guardian, except for this area in the red box, examiner signature. That's you, so you need to fill out this portion. Second page is filled out by the student and or their parent or guardian. I forgot one other thing that you want to look at on the first page. Um, you fill out this section as well. And so you need to ask them what sports they're playing. Are they contact or limited contact or no contact sports? And then you can see here that they can take part in anything um, or not cleared for all sports or specific sports. This page has the physical exam. The physician reminders, those are things you should be asking anyway, things like safety, depression, um, any drug use, anabolic steroid use. In the middle here is your section for the physical exam. So you have height, weight, blood pressure, vision, and if they wear corrected lenses. Genitourinary, even though it says males only here, you can put exam not completed if you didn't do it. It's not mandatory that you fill that out. But then the rest of the systems, you either want to check off normal or abnormal finding. If there is an abnormal finding, what it was. And then these are if any further testing is needed. And then here again, cleared for all sports without restrictions or cleared for all sports without restrictions. In this section, you might write something, for example, if they have exercise-induced asthma, you might write, recommend patient has their albuterol inhaler at all times when participating in sports. Or if you're not clearing them here, and then again, you're going to sign at the bottom. And for some reason, I don't know why this is the last page. I think it should be earlier on, but this should be filled out by the student or parent or guardian prior to you coming in the room. So it's the history form, it's all the review of systems. While you're in the room with the patient, you want to go through all of this and make sure that there are no concerning answers. Once you finish the sports physical form, and I cannot stress this enough, and this goes for all paperwork that you fill out for patients, you need to make a photocopy of all pages of it and have it scanned into the chart. And you also want to document in your assessment and plan that you filled out the form and that it will be scanned into the chart. Imagine a scenario where you have a patient who's coming in to do an annual exam. They ask you to fill out their sports physical form as well. If you don't make any mention in the note that you actually filled out the sports physical form, one of your colleagues may be seeing the patient later. The parent might say, "Oh, I lost that form. Can I get it again?" And we would have no idea that we had done it for them. So just always, always, always make a copy and put it in your note. Okay, so next we're going to go over some recommendations from various organizations for adolescents. So the first recommendation is for social media, and the recommendation is no more than 2 hours of screen time per day for children over the age of 2. That's really hard to do in today's working conditions for, well, both parents, but also kids. So many of them have been doing school from home. That counts towards screen time. But that is the recommendation. Healthychildren.org, this media use plan, this is put out by the American Academy of Pediatrics. I don't have it pulled up here, but at any time you can look at it. And it's a good tool for parents to be able to review what is safe social media use for their kids and what isn't. They can also do like a social media contract as well. So that's a really good resource. Again, when you're talking to kids, you want to ask them what sites or apps they use, how much time are they spending on social media each day, do they think they're using it too much, does it stress them out, are they using it before bed, and if they've ever um, had issues with cyberbullying or been involved in sexting, um, or definitely if anyone is asking uh, for the child to take part in sexual activity with them, is that um, something like a predator situation? Those are the types of things you want to be asking about and knowing. Okay, moving on to substance use. So it's estimated that 87% of adult smokers started smoking before the age of 18. Um, 20% of high schoolers had used marijuana in a study done in 2015. So, the American Academy of Pediatrics recommends screening adolescents for substance use and, if applicable, using a brief intervention, establishing follow up, and considering referral depending on the degree of substance use. So, remember before we were talking about doing the psychosocial screen. So, to do the SBRIT, the screening, brief intervention, and referral to treatment, the American Academy of Pediatrics recommends using the CRAFT screener. So just a bit about the screening, brief intervention, and referral to treatment. They recommend this is used for universal annual screening to identify unhealthy use. The brief intervention is providing feedback about unhealthy substance use, and then referral to treatment helps to facilitate access to addiction assessment and treatment. And using this technique is most effective when patients have unhealthy alcohol or drug use but do not have a substance use disorder. So the screener that the AAP recommends using is the CRAFT screener. So it's divided into two parts. So these are the questions you ask. In part A, you ask, during the past 12 months, did you drink any alcohol? Yes or no. Smoke any marijuana or hashish? Yes or no. Use anything to get high? Yes or no. So it's quite simple. If they answer no to everything, they get a score of 0. And in that part, you only ask question 1 in part B. If they answer yes to anything in part A, you ask all of the questions in part B. These are the questions in part B. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs when you're by yourself or alone? Do you ever forget things you did while using drugs or alcohol? Do your family or friends ever tell you you should cut down? Have you ever gotten into trouble while using alcohol or drugs? And again, it's a simple yes or no. So if the scoring is 0 or 1, you do brief advice like, I recommend you stop drinking or smoking or whatever the behavior is, and now's the best time. And you can read through that. If the result is 2 or more, then you do a brief assessment. So you're going to sort of ask them more specifically about their substance use. If you don't see any signs of acute danger or addiction, you do a brief interview and recommend that they cut down. If you see signs of addiction, you refer to treatment. If there are signs of acute danger, they recommend doing a contract for safety and consider breaking confidentiality, which is something that when you have that discussion with the adolescent about the confidentiality between you and the patient, that, you know, anything you said between us is stays between us. I don't tell your parents unless I have concerns about your immediate safety, not danger, that you are in danger. I'm not going to go through all of these, but this presentation will be posted for you so you can look back. These are some talking points for brief counseling. Sometimes you'll get parents coming in concerned that their child is using a certain substance, and they'll ask you to do a urine or blood test to test for drugs. And the AAP recommends against doing this, implementing school or home-based testing, and supports informing concerned parents about the limitations of such testing. And definitely, this is something that does come up quite often, and so it's recommended to not do that type of testing. These are some recommendations from the American Academy of Family Physicians. The current evidence is insufficient to assess the balance of benefits and harms of primary care based behavioral interventions to prevent or reduce illicit substance or non-medical pharmaceutical use in children or adolescents. And confidential screening and counseling should be offered regularly, including care related to sexuality, substance use, and mental health services according to state laws. And this is just regarding the SBRIT guidelines, that primary care treatment for adolescent substance use should be coordinated from other mental health experts. So, you know, if someone comes in with serious mental health and substance use, that you should be referring those people out and be a part of a collaborative team to treat them, not just yourself. Education and or brief counseling should be provided to adolescents to prevent initiation of or stop tobacco use. Brief interventions using components of motivational interviewing may reduce illicit substance use among adolescents. So looking specifically at alcohol, the U.S. Preventative Service Task Force found that there was insufficient evidence to assess the balance of benefits and harms of screening and brief behavioral counseling and intervention for adolescents 12 to 17. So this is just for alcohol, but you can see the American Academy of Family Physicians does recommend it, as does the American Academy of Pediatrics. And that, but you should screen those over the age of screen for unhealthy alcohol use in those older than 18, including pregnant women, and provide those engaged in risky or hazardous drinking with brief behavioral counseling. Looking at smoking, I'll let you read through these, but also insufficient evidence to assess the balance of benefits and harms of pharmacotherapy intervention or electronic nicotine delivery system for tobacco cessation in pregnant women. So not enough evidence there yet to recommend it. Looking at trends in sexual health, approximately 50% of new sexually transmitted infections occur in adolescents between the age of 15 to 24. And though the rates of chlamydia, gonorrhea, and syphilis were increasing through the period of 2012 to 2016, but decreasing rates of teen pregnancy due to increased contraceptive use. So this would again be part of your talk that you would try to have with the adolescent alone without the parent there. And you may want to open the conversation by asking, May I ask you some personal questions that will help me to understand what kind of health advice I can offer you? Again, you want to use gender neutral language. If you're discussing things and there's something that, a term that's used that you're not sure what it means, ask them what it means. Um, Ask direct questions and ask for clarification if needed. Describe how clinicians can help. Um, and abstinence, if practiced, should be reinforced. These are the AAFP recommendations for sexual health. Um, this is one that you'll run into often in the clinic, that if possible, you should use a long acting reversible contraceptive in adolescence as the first line contraceptive. Um, the USPSTF recommends screening sexually active women less than 24 yearly for chlamydia and gonorrhea, but insufficient evidence to screen males. But certainly, as part of your review of systems, you would be asking if there are any symptoms that those patients are concerned about, which might lead you to testing. Hepatitis B screening is recommended. Herpes screening is not recommended. Routine serologic screening in asymptomatic adolescents is not recommended, including women who are pregnant. So in this case, you only want to test if someone is complaining of symptoms consistent with herpes. HIV screening and syphilis screening, both for pregnant women and adolescents who are at increased risk for both. Looking at mental health, interestingly, if the child is younger than 12, depression is slightly more common in males, but after puberty, more common in females. And this is the questionnaire that we use in our clinic. It's actually built into our EMR. It's the Patient Health Questionnaire, or PHQ-9. Our MAs will ask the first two questions, and then if the test is positive, you as their physician should be going through the rest of the questions. So when it's modified for teens, they must answer question 1 or 2, which are over the past 2 weeks, little interest or pleasure in doing things, or feeling down, depressed, or hopeless. So they have to answer one of those two questions with a 2 or a 3. And they must answer at least 5 of the questions positive, and the functional impairment must be at least somewhat difficult. The AAFP recommends confidential screening and counseling be offered to adolescents regularly, including care related to sexuality, substance use, and mental health services. And that adolescents aged 12 to 18 and adults should be screened for depression when systems are in place to ensure accurate diagnosis, treatment, and follow-up. These are some more recommendations. Children and adolescents with moderate or severe depression or persistent mild depression should be treated with fluoxetine or escitalopram in conjunction with cognitive behavioral therapy. That's very important. The USPSTF has found insufficient evidence to start screening children for depression younger than 12, but they do, similarly to the AAFP, recommend screening adolescents 12 to 18, again, when there's effective treatment and follow-up in place. Looking at obesity, The recommendations are for 60 minutes of moderate to vigorous physical activity daily, optimization of sleep habits, and discussing healthy eating patterns. In terms of eating disorders, the recommendation is for family-based therapy, and this is more for anorexia or bulimia, and that this should be done with a multidisciplinary team, including yourself, dietitian, and a therapist. This is talking about screening using the BMI percentile, which we already talked about. Blood pressure screening. Children should have blood pressure measured annually beginning at age 3 at every health encounter in children who are obese, who have known kidney disease, aortic arch obstruction, coarctation, or diabetes, or who are taking medications known to increase blood pressure. For example, stimulant medications for ADHD. All children and adolescents with hypertension should be screened for hyperlipidemia and underlying renal disease, and do not routinely screen for hyperlipidemia in children or adolescents. And these are just the USPSTF recommendations. I'm not going to read through them, but you can go through that later. In terms of safety recommendation, the AAFP gives an inconsistent rating for adolescents being encouraged to wear seatbelts and to adhere to graduated driver's licensing laws and avoid distracted or impaired driving. I don't know why that's an inconsistent or limited quality rating. To me, that should be a grade C rating. Also, looking at safety, you want to ask about history of abuse, any gang involvement, any fear of assault. Do they feel safe at home? Do they feel safe at school? Are they being bullied? And any use of weapons. The USPSTF recommends screening women of reproductive age and providing or referring women who screen positive to ongoing support services. You'll notice in our office, in the bathroom, we have a number of different agencies for people who maybe don't feel comfortable bringing this up with their primary care provider. So it can be anonymous, that when they leave the bathroom, they can just pick up the resources and have that. But you should be asking about safety anyway to all of your patients. Folic acid recommendation. Insufficient evidence to screen for scoliosis in adolescents aged 10 to 18. In terms of cancer screening, cervical screening, you don't start doing PAPs in women less than 21. Skin cancer, you want to counsel young adults and adolescents with fair skin types about minimizing exposure to UV radiation. Really, you should just be recommending it to everyone, not just fair skin types. And screening for testicular cancer is not recommended. And these are some references. So this is the end of the presentation, and the slides will be available for you. There's a lot of recommendations in this from AAP, AAFP, and USPSTF, so take a minute to go over them whenever you get a chance.